Yes. So thank you for the introduction. So it's great to be here. So very briefly, prostate cancer, second most common cancer worldwide, fifth most common cause of cancer-related deaths in men. Neoadjuvant chemo-hormonal therapy is a promising novel treatment with good results. So you can see up in the figure there from the 2019 study, the patients that underwent chemical hormonal therapy did much better than those that did not, right? The red line versus the blue or green line, right? Nevertheless, most patients experience disease progression within 2 years. This is largely due to the fact that the tumors are heterogeneous. The typical multifocal prostate tumor has anywhere from 1 to 5 tumors. Foci, each of those foci is biologically different. So if even one of those escapes the treatment, the cancer will come back. And given that this is a fairly aggressive treatment, it is important to have biomarkers that will help us guide treatment decisions, that will tell us if the patient will benefit from treatment or not. Right. So with this in mind, a phase 2 clinical trial was conducted at the University of Wisconsin-Madison, 30 patients with locally advanced high-grade prostate cancer. These are very sick individuals. They were given androgen deprivation therapy. Then they were imaged with PET-CT and PET-MRI. They received 3 doses of docetaxel 3 weeks apart. That's the actual chemo-hormonal therapy. And then they were imaged again, and then they underwent radical prostatectomy. And so we collect radiological and clinical data at week 1 and week 10, the purple arrows indicated in the figure. These are the data features that we collect. So there are 7 radiology features, MRI, PET, and so forth, before and after CHT, so 14 total. And then we have 8 clinical features, tumor volume, pre-treatment, presence of metastatic disease, and then PSA density, and prostate volume before and after CHT. Some of these features are objective, meaning they are instrument readouts. Others are subjective, meaning they are evaluated by a clinician. So the objective features are preferable because they are more reproducible. And some of these features are cancer-specific, meaning they can only be caused by cancer. Others can be caused by other things. They are not specific. So the ideal features are those that are objective and cancer-specific. I draw your attention to standardized uptake value, tumor volume, and PSA. So we want to identify which features are associated with progression. We have our data. We also have our progression data for each patient. So of the 30 patients, 18 underwent progression, 12 did not. The progressing patients are shown in purple, and the height of the bar is the time at which progression occurred. The other 12 patients that are shown in green, they dropped out of the study without experiencing progression. So by the time they were censored from the study, these patients had not undergone progression. We call them the censored patients. So we combine the progression data and the clinical data in a House model to identify which features are associated with progression. Okay, so first, some results for the radiology data. So clearly here we have one feature that's far more significant than all the others. Standardized uptake value, that is a measure of glucose uptake by the tumor, right? So the more tumor, the more glucose uptake, the higher this value will be. And this is our most significant feature. It outperforms all the others. MRI and DWI a distant second and third, followed by SUV max pre, and then everything else is not significant. And as you recall, this feature is both objective and cancer specific. So it's a very fortunate result that our most significant feature is like that. We also look at the model concordance, bounded between 0 and 1, 1 being perfectly concordant. Standardized uptake value is at 0.75, 0.73, 0.74, which is pretty good considering the sample size. So that really is our top features. So in radiology, we have one feature that outperforms all the others. Looking at standardized uptake value a bit closer, we see it's elevated in patients that progressed, and it's generally low in patients that were censored, with some exceptions. Hazard ratio 3.6, which is pretty good, p-value 10 to the minus 6. And in the Kaplan-Meier curves there on the right, we see the patients with low standardized uptake value had far better progression-free survival than those that did not. Right, so really this feature stands out from all the others. Looking at the clinical data, again, we have a top performer. This time is tumor volume, and tumor volume is measured before treatment, so it's before CHT, so it's predictive, right? And you see there's our most significant feature, 10 to the minus 6, followed by PSA pre, PSA post, and then PSA density pre and metastatic disease. An interesting result is metastatic disease. So the presence of metastatic disease in the clinical setting is considered the best predictor of whether the patient will progress. So that's what clinicians use to guide their treatment decisions. Here, we see that it's not very significant, right? And this is because out of the 30 patients, there were 4 patients that had metastatic disease that did not progress, and there were 4 patients that did not have metastatic disease that did progress. So this data sort of doesn't give that much significance to metastatic disease. And again, we have one feature that outperforms all the others, and tumor volume also happens to be objective and cancer specific. And you see there the concordance, 0.75, so slightly better than standardized uptake value. And then when we look at the tumor volume, again, it's elevated in patients that progressed. It's generally low in patients that were censored. And then the Kaplan-Meier curves are even better than standardized uptake value. You see there, the blue curve, the patients with low tumor volume had far better outcome than the patients in red, right? So again, just like with the radiology data, we have here a feature that outperforms all the others. And then we combine the clinical and radiology data in a single model. And what we see here is that the combination of standardized uptake value and tumor volume is the most significant combination of features, which is not surprising considering these are our top features at the individual level. And it's the combined result is much more significant than either feature by itself, right? So 5 times 10 to the minus 8, 2 orders of magnitude more significant than either feature by itself. On the concordance front, things are relatively unchanged, 0.75, but that's still pretty good. Next, we look at the tumor volume and SUV max post for each patient. So we plot the patients, the figure on the left, and you see there the censored patients, the ones that did not progress, are clustered on the bottom left, right? So patients with low SUV max post and low tumor volume were the ones that were censored, that did not progress. So it seems that these are the patients for which the treatment was effective, and anybody with high tumor volume or high SUV max post was unlikely to benefit from treatment. And then you can also see that in the Kaplan-Meier curves, right? The patients with low SUV max post and low tumor volume, almost 0.8 fraction progression-free, right? Much better than the ones with either high tumor volume or high standardized uptake value. Next, we added more features to the model. So models with 3 features, so any 3 combination of features. So our top performer is tumor volume and standardized uptake value. With metastatic disease, but only a slight improvement in significance really doesn't make that much of a difference. And this makes sense because standardized uptake value and tumor volume are so significant by themselves that adding a relatively non-significant feature is not going to change things very much. And then same thing with 4 features. So here, any combination of 4 features, really no improvement in the significance, right? So to conclude, standardized uptake value, pro-CHT is our most significant radiology feature. It's post-treatment, so it's diagnostic. Tumor volume is our most significant clinical feature. It's pre-treatment, so it's prognostic. Combining tumor volume and SUV max results in a major increase in significance. Adding more features to the model really does not result in any major increase in significance. And from this clinically, we conclude that patients with low standardized uptake value and low tumor volume are the most likely to benefit from treatment. Anybody with high tumor volume or high standardized uptake value is unlikely to benefit from treatment. And for more info, you can come to my poster tonight or shoot me an email if you can't make it, and I'd be happy to take any questions.
Thank you very much.
Thank you. Really interesting. I'm wondering, especially because you just ended up mentioning that you interpret your results as what would, or which patients would benefit from the treatment. But I'm wondering a bit because if all the patients are treated in this cohort, we don't have information of whether they will progress regardless of the treatment, or if it actually was beneficial for them, maybe by a lot, but they were already in a really at-risk group compared to patients, for instance, with smaller tumor volume.
Yes, that is a good observation, but what we know is that all these patients were extremely sick before treatment, so that's why there's no control arm. So these are patients that are very, very ill, their cancer is very advanced, so there's no real difference between them.
Thank you. Other questions? So I would have one simple question and quite naive. How much is this work kind of like specialized for prostate cancer, or can it be applied to other types of cancer?
That's a great question, and I'm not really sure, but this particular study was very much focused on prostate cancer. So most likely we'll publish it in a prostate journal.
And actually a follow-up question, what would be your future plans kind of into lens?
Future plans, we'd like to integrate additional data, RNA-seq, DNA-seq flow cytometry, develop a multiple instance learning model, and also instead of a Cox regression, try a random forest. So these are currently things we're working on, so maybe next year.
Thank you very much.